Thank you everyone for joining us here today. I'm glad to have the opportunity to speak on PET RANO 1.0 and how metabolic imaging can be integrated more meaningfully into response assessments for diffuse glioma. Before we dive into the details of today's talk, I'll give you a quick roadmap for today's discussion. I'll begin with an overview of PET RANO, what it is, why it was developed, and how it fits alongside conventional MRI-based RANO criteria in diffuse glioma management. From there, I'll move into the foundation of PET RANO, including the amino-acid PET tracers that fall within the framework and the quantitative PET parameters used to define and evaluate PET-positive disease. Next, I'll cover disease classification and baseline assessment. Because before we can talk about response, it's important to understand how PET-positive disease is characterized, how target lesions are selected, and how baseline PET should be timed. I'll then walk us through the response assessment framework itself, focusing in on how PET RANO defines stable disease, partial response, complete response, and progressive disease using the standardized metabolic criteria. And finally, we will close with the applications of PET RANO, which includes key rules and clarifications, some practical considerations for clinical trial implementation, some of the current limitations, and a few examples that highlight where this framework may add value in practice. And so with that overview in mind, we'll start with a very high-level introduction to PET RANO. And so at a high level, PET RANO provides a structured framework for incorporating amino-acid PET into response assessment for glioma. It is not intended to replace MRI-based RANO, but rather to complement it by adding metabolic information that MRI alone may not be fully able to capture. And for those of us that work in clinical trials, that distinction is important. We're not talking about a completely separate response system that replaces or disregards MRI. Rather, this can be a more complete imaging strategy, one that can help reduce ambiguity when MRI findings are difficult to interpret. And so what is PET RANO? PET RANO is the first formal effort to standardize these PET response assessments specifically for diffuse glioma trials. And this matters because amino-acid PET has been used for many years in neuro-oncology, but its use in trials has been limited by inconsistency, differences in acquisition, interpretation, lesion definitions, and response thresholds. And PET RANO can start to address that by giving us a shared framework and common terminology. And from a CRO perspective, that's really where a framework like this becomes operationally meaningful, because once we can define disease consistently, target lesions consistently, and change over time, then the central review process becomes much more reproducible. And so why are we using PET RANO, and where does the need for PET RANO come from? And really it comes from the limitations of MRI. MRI remains the backbone of glioma response assessments, especially after chemoradiotherapy, but interpretation can remain challenging. Enhancement that can reflect more than viable tumor. It can also be influenced by treatment effect, inflammation, corticosteroid use, and radiation-related changes. And of course, pseudoprogression remains one of the biggest challenges in that early post-treatment imaging time point. Amino-acid PET adds a different kind of information. And so instead of focusing primarily on structural or vascular changes, it gives us a metabolic readout that may better reflect active tumor biology, and that can be especially valuable when our MRI findings are equivocal. And in clinical trials, this matters because the uncertainty in imaging interpretation can directly affect the endpoints, the treatment continuation, and the overall confidence in response assessments. And so the role of amino-acid PET is not relevant only at a single point in time. Its utility can span the full disease course, from diagnosis to biopsy and surgical planning to radiotherapy planning, and then even into follow-up and response assessment. And so what PET RANO is doing is taking that broader clinical value and focusing it into a trial-ready response framework. And so, in other words, we're taking something that's already been clinically useful and we're asking how can we use it consistently over time in a way that can support structured response assessment. And this is a really important distinction because a lot of imaging tools can be clinically informative, but not all of them are standardized enough to be able to support endpoint-driven decisions. And so PET RANO is trying to bridge that gap. And so before we get into the response categories, we can establish the technical foundation of the framework. PET RANO will depend on a few core elements: which tracers are included, how PET positive disease is defined, and which quantitative parameters are used to assess change over time. And these details often seem technical, but they are central to the reproducibility of studies. If the underlying measurements are not standardized, then the downstream response criteria will not be reliable either. And so in the next few slides, we will focus on building the building blocks that make the framework. And so as I mentioned previously, PET RANO applies specifically to amino-acid PET tracers. The main tracers commonly discussed are FET, MET, F-DOPA, and fluciclovine. And the reason these tracers are important is that they generally provide a better tumor to background contrast in the brain than FDG. And that is why FDG, although widely used in oncology, it is not ideal in this setting. And from a trial design perspective, the tracer selection also has practical implications. It affects site feasibility, standardization, and even comparability across centers. And so if PET is being incorporated into the study, this tracer cannot be treated as a secondary detail, and it needs to be specified early, and the review strategy needs to be aligned with that choice. So this slide covers the measurement framework that underpins all of PET RANO. And there are 3 key steps, and consistency across all 3 steps at every site and at each time point is what makes the framework work. The first step is defining the background activity using a crescent-shaped volume of interest in the healthy-appearing contralateral brain. That reference value then anchors step 2, where region within uptake at above 1.6 times the mean background activity are segmented using a threshold-based approach. And then we have step 3, which will extract the quantitative metrics of SUV max, SUV mean, TBR max, TBR mean, and PET positive tumor volume. TBR, or the tumor to background ratio, is particularly important because it will normalize uptake against the patient's own normal brain, making it a more stable across scanners and sites than the raw SUV values alone. And one rule that's often easy to overlook, but that has important downstream consequences, is that if no region in the scan can meet the 1.6 times threshold, then no PET positive volume can be delineated. And then if that happens, the TBR max and the TBR mean cannot be calculated. And that constraint can directly determine which response categories are available to the patient, which is what we will cover in the next section. But from a CRO perspective, all of this, the background placement, the thresholding, the normalization method, needs to be fully pre-specified in the imaging charter before the first patient is scanned. And so now that we have this technical foundation in place, the next step is understanding how PET positive disease is classified at baseline. It is important because baseline classification will determine what kinds of response categories are even possible later on. PET RANO does not treat all visible uptake the same way. It will distinguish between measurable and non-measurable disease, and that distinction will drive how follow-up is then interpreted. And so before we talk about response, we need to first define what kind of disease are we starting with. And so in the context of measurable and non-measurable PET-positive disease, PET RANO 1.0 PET-positive disease is defined quantitatively, where again, the tumor uptake has to be at least 1.6 times the mean background activity. But from there, disease can be classified as measurable or non-measurable based on PET-positive tumor volume. If the volume is at least 0.5 milliliters, it is considered measurable. If it is below that threshold, or if there is invisible uptake that does not meet the quantitative cutoff, it is considered non-measurable. That may sound like a small distinction, but has real consequences in trial execution. In trials, measurable disease criteria often determine whether the formal categories such as partial response or complete response can be assigned. And so this isn't really a descriptive point, but it will directly affect the endpoint interpretation. And this is one of the other more important rules in PET RANO. If a patient does not have measurable PET-positive disease at baseline, PET-based partial response and complete response are not applicable. Assessment in that setting is limited to stable disease or progression, where progression will be defined by the development of measurable disease or the appearance of new measurable lesions. And for a trial audience, the value of this rule is that it can prevent overcalling response when there is insufficient measurable metabolic disease at baseline to support it. It also means that baseline classification has a direct effect on how informative PET can be later on in the study. And that's a relevant consideration when determining the eligibility criteria and the primary endpoint definitions. And so when measurable disease is present, target lesion selection will follow. PET RANO recommends 2 to 3 measurable PET-positive target lesions that are selected at baseline and then followed consistently over time. An important nuance of PET target lesions is that it does not need to match the MRI target lesions. And that makes sense because the two modalities of MRI and PET will reflect different aspects of tumor biology. Operationally, this means that there has to be a very clear lesion level documentation, because without clear documentation from the start, reconciling findings across these different modalities later in the study will become much more difficult. The timing of baseline PET is defined in PET RANO and differs between newly diagnosed and recurrent glioma. In newly diagnosed glioma, baseline PET should be obtained within the first 14 days before the start of any post-operative treatment. If there is no post-operative treatment planned, the imaging is recommended 4 to 6 weeks after surgery, once early nonspecific post-operative uptake is less likely to confound any interpretation. And in a third scenario, if there is no surgical resection performed at all, a pre-operative PET can serve as the baseline, provided that the interval to treatment initiation does not exceed the 14 days. Across all these scenarios, the principle is to image as late as feasible within the allowed window, with early post-operative uptake can be very nonspecific and will contaminate the baseline reference if imaging is done too soon. For recurrent disease, the same principles will apply. Baseline PET should be as close as possible to the next therapeutic intervention, with appropriate allowance for any post-operative effects if resection occurred. These timing windows are the type of detail that needs to be tightly defined in the protocols and imaging charters. If they are left vague, the baseline comparability becomes inconsistent across different patients, and that inconsistency can carry forward into any downstream response assessment. And so now that we have defined measurable disease target lesions and baseline timing, we can move into the actual response framework. At this point, the logic becomes pretty familiar to anyone who works with oncology response criteria: complete response, partial response, stable disease, and progressive disease. But the way that these categories are assigned here is, again, based on the metabolic PET parameters rather than the conventional MRI measurements. And the key idea is this PET RANO will translate the metabolic change into now a structured response category in a way that's intended to be both objective but also reproducible. And so this table provides the summary reference for this framework. And before we walk through the individual categories in the following slides, one of the important concepts to highlight is the reference point used for comparison. Throughout PET RANO, change is assessed relative to baseline, or when applicable, relative to the post-treatment metabolic nadir. The nadir reference becomes especially important when treatment-related fluctuations in metabolic activity can complicate interpretation. And we can come back to some of that when we go and reach progressive disease. But for a trial team, a table like this can be very useful because it confirms that PET RANO is criteria-driven. But it's also worth noting that every threshold in this table will depend on consistent image acquisition, lesion tracking, and on quantitative analysis. And a lot of this criteria can appear straightforward, but require a significant amount of methodological discipline and execution. And so we will start off with the favorable response categories. Complete response requires measurable PET positive disease at baseline and is defined by the complete disappearance of all PET positive disease. Partial response also requires measurable disease at baseline and is based on quantitative improvement, either a decrease in TBR max, TBR mean, or PET positive tumor volume. One other important rule is that if multiple target lesions are selected at baseline, each target lesion will have to meet at least one response criteria for partial response to be assigned. And then stable disease becomes the default category for when criteria for response or progression are not met. In patients without measurable PET positive disease, the stable disease is defined by the absence of new measurable lesions. And then on the progression side, PET PD is defined by the worsening in at least one target lesion. Either a 30% increase in TBR max, a 10% increase in TBR mean, or a 40% increase in PET positive tumor volume. And only one of those criteria needs to be met. In patients without measurable baseline disease, progression is defined by the appearance of any new measurable PET positive lesion. Progression definitions drive major study decisions, and that will determine whether a subject discontinues treatment, whether a time to event endpoint is triggered, or whether discordant imaging findings require adjudication. And like I had alluded to before, a point that's easy to overlook is the nadir reference point that we mentioned in the summary table. PET RANO compares follow-up scans to this metabolic nadir and the lowest measurement recorded. And so rather than always going back to the baseline. And the reason is that metabolic activity will often drop transiently after treatment begins before potentially rebounding as that tumor regrows. And so if you only compare back to the baseline, a patient who reached a metabolic nadir is now progressing, may still appear stable relative to where they started. And so the nadir comparison can then catch that. And this is particularly important in patients that are receiving anti-angiogenic therapies, where MRI enhancement can be suppressed independently of tumor activity, which makes the PET nadir potentially the more meaningful biological reference point for detecting true tumor regrowth. And so this workflow simplifies the decision logic into a clear pathway. The entry point for the baseline is that baseline question, and is measurable PET positive disease present? If yes, the target lesions are selected and followed longitudinally with quantitative assessments at each time point. But if no, the assessment narrows considerably, with the focus in now on whether measurable disease emerges, and the possible outcomes are then limited to stable disease or progression. For trial execution, this workflow needs to be translated into reader instructions with review system logic and adjudication rules. It's also a framework that's useful in keeping alongside imaging charters throughout the study, particularly for reader training and baseline versus nadir distinction, and for documenting how the non-measurable disease pathway is handled. And so up until this point, we focused on the framework of what PET RANO is, how PET positive disease is defined, and how response is assessed using these standardized metabolic criteria. But it's also worth noting that since publication of the original criteria, additional papers have begun to apply this criteria in practice, which reflects a growing uptake in the field. And so with this foundation in place, I'd like to shift our discussion to how this approach can actually be used in the clinical trial setting. And here we will have questions about protocol design, operational implementation, and then the integration with MRI becoming especially important. And so at this point, I'd like to hand it over to Jean, who will take us through the application section.
Thank you very much, Veronica. So building on that foundation and with growing literature begins to apply these criteria in practice. So I'll start this section with some of the key PET RANO 1.0 rules and clarification that are especially important when thinking about the real world and clinical trial implementation. So the PET RANO 1.0 runs alongside with the MRI RANO. So the both assessment are conducted and reported, and your protocol needs to pre-specify exactly how they interact. Is PET the primary endpoint, or is the MRI, or are they the both co-primary endpoint? That decision has downstream implications and cannot remain ambiguous in the protocol. The second is progression under the PET RANO 1.0 can be triggered by any single qualifying metabolic criterion. One threshold crossed in a one target lesion is sufficient for the PD. Reader needs to be trained on that explicitly. The instinct to look for confirmation across the multiple metrics before calling the progression is not consistent with how the framework is defined. And lastly, the baseline measurability governs which response categories are possible throughout these studies. A patient without the measurable PET positive disease at the baseline cannot be classified as a responder, regardless of what happens clinically. That is the hard rule and a not judgment call. And this slide begins to move from the concept into the trial design. Amino-acid PET can add values at several points in glioma trials, from tumor detections and surgical plannings to baseline assessment and longitudinal response evaluation. But if PET is going to be part of the protocol, its purpose needs to be clearly defined. Will it be exploratory or is it supportive endpoint? Is it expected to contribute to the progression assessment? Those are the very different use cases, and they affect how the imaging charter is written, how sites are qualified, and how the data will ultimately be interpreted. That is where the CRR lens becomes especially important. The science may be strong, but the protocol still has to be specified exactly how the PET will be used in the trial. And this is really the operational core of using PET RANO 1.0 in a study. There are three major components here. First is the standard acquisitions, timing, injected dose, uptake period, and reconstructions all need to be harmonized across the sites. Second is a quantitative analysis, the background, volume of interest, thresholding approach, and normalization method needs to be pre-specified. And the third is the workflow. The target lesion must be locked at the baseline, discordance handling must be defined, and the reader qualification needs to be appropriate for the amino acid PET. And this is where the imaging charter becomes critical. Without the level of the pre-specifications, it becomes very difficult to apply the PET RANO consistently across the multi-center studies. So if there is a one operational takeaway here in this slide, it is the PET RANO 1.0 is not just a reading rule set, it is also a protocol and a workflow challenge that needs to be designed upfront. One of the most practically important questions is how the PET and MRI findings should be handled when they do not agree. Concordant progression is straightforward, and concordant favorable response is also relatively straightforward. The challenges in discordance, for example, the MRI stable disease with the PET progressions, or MRI progressions with the PET findings that appear more favorable. Those scenarios cannot be left vague. The protocol and imaging charters need to define in advance whether PET can trigger the progression, whether the discordant findings require adjudications, or whether they should trigger closer follow-up rather than a immediate endpoint event. This is where the PET becomes both valuable and operationally sensitive. It may identify biologically active disease earlier than MRI in some cases, but if the trial has not pre-specified what to do with the information, it can create confusions instead of clarity. Since publication of the PET rating 1.0, the broader evidence base supporting amino acid PET has continued to grow. The main themes are quite consistent. Amino acid PET can identify metabolically active tumor beyond what is visible on MRI. Quantitative PET metrics can support the more objective disease characterizations, and overall diagnostic performance appears favorable compared with the FDG in the brain tumors. For a trial audience, that growing evidence is important because it supports the biological relevance of what PET RANO 1.0 is measuring. It tells us that these criteria are not being developed in isolation. They are grounded in a body of literature showing the amino acid PET captures clinically meaningful tumor biology. That said, the supporting evidence is not the same as the full endpoint validation, and that distinction remains important from both a regulatory and a trial design standpoint. So here we have a few case studies that we wanted to feature here. The first case study examines the 11C methionine PET MR in patient with the high-grade glioma, comparing with the PET-based and MRI-based response classification in the same cohort. The central finding was that the PET-based response classification stratified the overall survival more clearly than the MRI-based response. Patients classified as a PET responders demonstrated meaningfully better survival outcomes than the non-responders, while the MRI response in the same cohort did not achieve the same degree of the stratification. The source code for this finding warrants confirmation before citing in detail, but the pattern is consistent with the other data suggesting metabolic response carries a prognostic information that the MRI-based response assessment does not fully capture. And the second study applies the PET RANO 1.0 criteria directly alongside with the MRI RANO 2.0 to a glioma cohort treated with the temozolomide. Both assessments were conducted in the same patients at the same time points, allowing a direct parallel comparison. PET RANO response significantly stratified the overall survival. Patient classified as a stable disease, partial response, or the complete response had a median overall survival of 16.8 months compared to the 12-month in the PET PD, with a p-value of the 0.016. That finding remains significant in the multivariate analysis. A hazard ratio of the 4.185 with a p-value of the 0.002. It is worth noting that the PET RANO response did not significantly stratify the progression-free survival in the cohort, which is 9.7 versus the 8.1 month, with the p-value of the 0.147. That is an honest finding and a one worth acknowledging because it suggests the metabolic signal has stronger prognostic value for overall survival than the PFS in this setting, and that distinction matters for the endpoint selections. MRI-RANO 2.0 did not significantly stratify either PFS or the OS, and the PET and the MRI classifications were frequently discordant. Taken together, both cases studies support the premises that the metabolic response assessed by the amino-acid PET carries prognostic information for overall survival that the MRI-based response does not fully capture in these cohorts. As with the any single center cohort data, these findings require broader validation, including in prospective, randomized settings, before the PET RANO 1.0 can be considered a validated primary endpoint. Before closing, it is also important to be transparent about the current limitations of this PET RANO framework, because these are questions that any trial incorporating PET RANO 1.0 should be prepared to address. The most significant limitation is that the PET RANO 1.0 response criteria has not been validated as a primary endpoint in a prospective randomized control trial. The supporting evidence, including the case studies presented today, comes from the single center cohort studies, and the broader perspective validation remains in the field's critical next step. Scanner and the platform standardization is another real operation challenge. Tumor to background ratio values are sensitive to different in acquisition protocols and also risk construction algorithm. Achieving comparable values across the site requires systematic harmonization of work during the study startup. Also, the 1.6 times the background threshold may also not perform equally across the all tracers, tumor subtypes, or the treatment context, particularly in IDH mutant versus the IDH wild-type gliomas, which remains an area of the active investigation. And finally, PET RANO 1.0 uses static uptake measure only. Dynamic parameters such as the time activity curves are not incorporated, despite the evidence suggesting they may provide additional prognostic information. So to close the scientific section, the PET RANO 1.0 gives the field something it has not had before, a standardized, consensus-driven framework for incorporating metabolic imaging into glioma response assessment. The evidence base supports that the operational requirements are well defined. As the case study illustrates, it may provide the prognostic information that MRI-based response assessment does not capture. And I can pass this presentation back to Catherine.
Hey, thank you, Dr. Matzik and Dr. Kim, for the overview of PET RANO. I know in speaking with sponsors, it is so important to have an imaging partner that is well versed in a variety of reading criteria. And before we move on to our final portion of today's webinar, I wanted to share references today and also a reminder that this information will be available on our website and on our YouTube page. So who is Merit? Merit has served biotech and pharmaceutical companies in their clinical endpoint analysis for over 14 years with a team of medical professionals and seasoned operational support staff. Our company originally started in ophthalmology, but it has expanded to include oncology and respiratory therapeutic areas as well. We are based out of Madison, Wisconsin in the United States, but our company has a global reach. We also have offices in China, Australia, and Canada. We have team members and reading centers around the globe, making it possible to support sites and sponsors from a variety of locations. Our approach is to focus on 3 key areas. Our software system, Excelsior, can handle all aspects of an imaging core lab in one transparent system. From acquiring images from a study site to performing an independent read and transferring data to a sponsor, Excelsior can manage and track images throughout every step of the process. Merit also has a large network of over 300 radiologists and oncologists to help support studies in a variety of therapeutic areas. And finally, at Merit, we value a collaborative partner approach, working closely with our sponsors and CROs and sites to build trust, partnership, and long-term relationships. And in addition to the therapeutic area expertise and medical knowledge that the Merit team brings to our sponsors, our project management team brings a wealth of experience in a variety of study phases and study designs. Our sponsors benefit from our Excelsior system, which offers a single, transparent, and easy-to-use application for the entire study process. Excelsior is programmed with a variety of response criteria, and the flexible system can be configured to manage many different study designs and accommodate all relevant modalities. Thank you for joining us today. We will now open up the webinar for questions. Please feel free to submit them through the Q&A function, and we will address as many as possible during this webinar. And while you are submitting questions, I also wanted to share our upcoming conference schedule. We will have team members who are available to meet you in person at several upcoming industry conferences, including SAPA GP, AACR, ASCO, and SNMMI. You can see the information here on the screen with dates and also our booth locations. Okay, so we do have a few questions that have come through. Thank you to those that have submitted questions. If you haven't done so already, please feel free to continue to use that Q&A portion of the Zoom. Okay, so the first question, Dr. Matzik, I'm going to pass this one to you. It says, in the era of immunotherapy and targeted treatments, do you see metabolic response becoming a surrogate endpoint for survival?
That's a great question. I think something that we think about a lot. I think right now metabolic response is moving closer to that role, because I think a lot of new therapies make a lot of the conventional MRI response assessments a lot more difficult to interpret. And so I think in those settings specifically, the metabolic readout is probably a better reflection of whether the therapy is truly affecting the active tumor biology that is going on in response to the therapy. But I think that we're still pretty early on in understanding both metabolism and metabolic response. So I think that for now it'll probably be a promising supportive or like an intermediate endpoint instead of a fully established surrogate for survival, because I think a lot of this needs to be validated across larger cohorts. And I don't know if we have enough evidence currently to say, that the treatment-related changes in metabolic response can really reliably translate into survival benefits for patients. But I think over time, as we learn more about the biology and we learn more about the tracers, we can probably definitely get to a point where we can use it a lot more effectively, much like what we do currently with MRI.
Okay, that's great. Thank you. Okay, we have another question. How does PET RANO handle pseudoprogression differently from MRI-based assessment alone? That, Dr. Kim, I'm going to pass this to you, but I know that is a great question. I speak to a lot of our sponsors. They are always very interested in pseudoprogression. They want to know how to handle it in their study design and also how to incorporate it into the charter. So what is your take on that?
Thank you for the question, and I think that's a great question. So mostly the standard is the anatomical assessment of the RANO or the RANO 2.0, which solely based off on the actual structural enhancement size increases. So that sometimes not be able to tell the actual functional characteristics of the lesion area. So this is where the PET RANO, which the amino acid PET can actually capture the actual uptake of the viable active tumor where the lesion increase is correlated, which you can tell it's more of a true progression in that case. And if the PET renal still gives you a non-progression, stable or no uptake, where the lesions are actually increasing in the size, that is more likely to provide information that the lesions does not have an actual viable tumor, but it's something related to the post-treatment changes, or the more or less you can call it like a pseudoprogression in that case. And those important rules should be definitely specified in a charter, how to handle those two different directions of the information between the PET and contrast enhancement and MRI basically. Yeah.
Okay, great, thank you. Okay, we have another question. Is PET RANO more useful in newly diagnosed disease or in disease recurrence? Dr. Matzik, can I pass that one to you?
Yes, you can. Thank you. Um, I think I think both settings, PET Rano can be very useful, but I think the use case of PET Rano in both is obviously different. So when we think about newly diagnosed disease, we think about the fact that PET can be helpful in distinguishing any of those post-treatment um, or essentially elucidating those post-treatment MRI findings that are often very ambiguous and hard to understand because treatment-related changes are impacting that. And so it gives us another layer to be able to monitor aside from just the MRI. I think in the context of tumor recurrence or recurrent disease, um, the existing issue is that it's really tough to or to distinguish where there's active tumor from areas that are post-treatment effects. And so that's also a significant challenge. And so I think that like it's not that one setting will particularly be more useful than the other, but um, the clinical questions that we get from them will be slightly different based on what type of disease the patient has. But I think it's just like another lens we get to use in the clinic and studies to be able to pick apart what actual biology exists with the treatment.
Great, thank you.
Mm.
Okay, it looks like we have one more question that was submitted. So the question is, are the current PET RANO thresholds likely to hold across all tracers? And Dr. Kim, if I can ask you to chime in on that one.
Thank you. Yeah, so for these threshold for a calculation of the PDs or the responses are still something that the field is still working on. So there are a couple tracers that the tumor to the background ratio to the contralateral uh, area of the background ratio might actually work better. And some of the tracers has known to actually reflect better with the SUV max or the SUV mean itself of um the uptake values are better reflecting. So there are a couple different tracer properties to that, which metrics of the uptake will actually best reflect those post-treatment change related cutoff of the SUV or the TBR. So this will be something important to really specify also in a protocol or to make sure that things are harmonized across different sites, especially when there are trials that you're actually working with the multi-center, and then you want to make sure that either the tracer is harmonized or we have the right evidence to support each analysis for the different tracers. Yeah, thank you.
Great, thank you. Okay, well, those were all the questions that we received. I want to thank everyone for submitting your questions. I especially want to thank Dr. Kim, Dr. Matzik for joining us today and sharing information about PET RANO 1.0. I think it's, a new response criteria that a lot of people are interested in. So it's great to have this overview. I want to thank every one of you that joined us today for taking the time to talk about PET RANO with us. And just as a reminder, this presentation will be available on both our Merit website and also our YouTube page. So please make sure to check that out. I hope you enjoy the rest of your day and thank you so much.